tonight we are about to finish all our course, and we are going to start with the closest module to my heart, which is the module of complications. Yes, tonight we are honored and privileged to have one of the most eminent and pioneer oncosurgeons, Professor Islam Hany, who is Associate Professor of Surgical Oncology, Oncology Center, Masson University, and one of our key GIT surgeons in our GIT oncosurgery team. Who is going to basics of GIT surgery and complications in gynecology. Thanks, Islam, for being with us, and the floor is yours.
Okay, welcome everybody. Good night. Sorry for this marginal delay. Okay, so we're gonna start with our GIT surgery complications and role of surgery in gynecology. It's not a very short one, anyway. Okay, so our outlines is the magnitude of the problem, how to preoperatively plan patient going for GI surgery, power resection, how to do safe anastomosis, about stool diversion, about anastomotic leak and complication, which Dr. Basil do like, alternatives to power resection, rectal injury, and enhanced recovery protocol. So first, the magnitude of the problem. Most of the published about the magnitude of the problem is about ovarian cancer mainly. So in 72% of patients with advanced ovarian cancer, we will have a visible tumor in the small or in the large bowel. This will end up with 40 to 80% of patients going for cytoreductive surgery for advanced ovarian cancer to have some sort of radical GI resection. In Series database, this is about 34%. Going down to 17% in Korea and Germany after neoadjuvant chemotherapy. So first step one is preoperative planning. How we do that, we need to do CT scan with oral contrast, and it's very important to give an oral contrast. If you're gonna plan for how much of the GI is affected by the tumor from outside, whether the transverse colon or the rectum or the small bowel, so you need to do oral contrast with the CT. If you are anticipating that the rectum or the anal canal, especially below the peritoneal reflection, the lowest 7 or 8 centimeters of the anal canal is, or the rectum is affected, you need to have an MRI better with rectal protocol to see the degree of infection exactly. You may need to do colonoscopy if there is suspicion for mucosal or fold thickness infiltration. So we do CT scan with oral contrast, plus or minus, we may have MRI rectal protocol, plus or minus colonoscopy. Second step, so would we prepare this patient, do some sort of bowel preparation before surgery or no? And if we go for that, there is much debate about bowel preparation in general in colorectal surgery, whether it's gynecologic or not in gynecologic. The NICE recommend against bowel preparation to decrease surgical site infection, so they don't think that mechanical bowel preparation decrease surgical site infection or wound infection. So there is no enough data to support, especially in right-sided tumor, and there is no data at all to support bowel preparation in small bowel resection anastomosis. However, the European Society of Coloproctology have done a large study, like audit study in 2017, and they found that mechanical bowel preparation plus oral antibiotic or oral preparation, they decrease both surgical site infection and anastomotic leak, and this was in left-sided lesions. And later on, the American Society of Colorectal Surgery do recommend mechanical bowel preparation plus oral antibiotic in electively based colorectal resections, whatever the cause. And this is reflected again in the WHO guidance. So to sum up that, we don't have any evidence to do bowel preparation for small bowel. There's limited evidence in the right bowel, but for the left bowel, mechanical with oral may decrease surgical site infection and may decrease anastomotic leak. Do left-sided resection. It sounds question.
Sorry, because I have a question, not a question really, but this is something that I have noticed here lately, and I notice very frequently in Cairo, that patients who are going to go a very straightforward hysterectomy, either open or lab, they are going to be bowel prepared. So do we have any evidence for this bowel preparation? Because it's very strange for me. Just a simple hysterectomy or a laparoscopic simple hysterectomy, and then usually the question I encounter from the colleagues in Alexandria and Cairo or the fellows, are we going to do bowel preparation for the patient or not?
So this would be the answer exactly in this, in the next slide. So there's strong recommendations from the Enhanced Recovery Society not to routinely preoperative bowel prepare patient going for gynecologic surgery if you are not planning or anticipating that you are gonna do large or left-sided large bowel resection. So it's not routine to do that with hysterectomy or either lab or laparoscopic or open. You don't do that. I don't think that. I don't think that this works. No, no, at all. Except that, as I say, if you are gonna planning that you are doing rectal resection for advanced cervical cancer, for example, or for ovarian cancer infiltrating significantly the wall of the left side colon, you may do, and in this case, do both oral and mechanical, not mechanical alone. And how to do that? So the oral antibiotic preparation is to give two of these three antibiotics, neomycin, metronidazole, or erythromycin, any two of which, and they are given in 3 doses the day before the operation. And for the mechanical preparation, you can do that with some protocols like movie prep twice daily, and you may do rectal enema, plus or minus rectal enema the morning of the operation, and the day before, just juices with low fiber content, like apple juice. Okay, so you give low fiber juices the day before the surgery, give 3 doses of antibiotics and two movie prep and one rectal enema if you are gonna do rectal resection. So the second step, the first step was preparation. Second step is how to do the resection. And so we have two things. Either we are doing left-sided resection or small intestine resection because it's infiltrated. And this how to work. You need to look at the mesentery of the small bowel. Either do that with transient illumination or palpate the vessels, and then you open windows in between the vessels in the mesentery. And this is called windows of Dever. So this is some avascular points between the vessels, and then you can after controlling all these vessels, you can cut either with two endo GIA on both sides, linear staplers, or use crushing and non-crushing clamps and dissect on both sides. Another thing, when you resect on both sides, you bear in mind that the blood supply on the mesenteric border is much better than that on the anti-mesenteric border. عليكم السلام. إيه؟ I told them because it's technical. Okay. So bear in mind that the blood supply in the mesenteric border is much better than that in the anti-mesenteric border. So when you gonna cut more anti-mesenteric than mesenteric. Cut like sloping, more anti-mesenteric side and less on the mesenteric side, so that you can have the better blood supply at the end of the anastomosis. So this is for the small bowel resection. For the rectal resection, we have these main types of rectal resection. If you are gonna resect part of the rectus sigmoid or higher parts of the rectum, it's high anterior section. If you're gonna do lower sections, low anterior section, which is the common procedure. Ultra low, if you're gonna have an anastomosis between 4 to 7 centimeter, just below the peritoneal reflection, just above the elevator inline. Otherwise, you can do abdominal hernia section. There is some sort of other section like intersphincteric, which will have very minimal role in gynecology. Will be mainly for rectal cancers. Okay, so this is how we're gonna resect the rectum in the 15 centimeter. Another thing, we have a procedure called Hartmann's procedure. You need to know the name of this procedure. This how it works, as in this slide. So we can see that there is a lesion infiltrating the sigmoid, either from inside or from outside. And then if you resect the sigmoid and redo the anastomosis between the colon and the rectum, this is called an anterior resection. Whether it's low, high, or ultra low, it's an anterior resection. If you didn't do an anastomosis, just close the distal stump and proximally divert, it's called Hartmann's procedure. So Hartmann's procedures is not a stoma, it entails resection and no anastomosis. This is what we call Hartmann's procedure. So the other question, shall we do anatomic resection in gynecology as we do in colorectal cancer, or just segmental resection for the affected part? And there is no evidence to suggest that anatomic resection or high ligation of inferior mesenteric vessels or high ligation of the branch of the superior mesenteric vessels would differ, because we do that in colorectal cancer to control the lymph nodes, which is not the best way for lymphatic spread for the ovarian or the gynec cancer. Okay, so you can just do segmental resection and cut the vessels flush to the wall. You don't need to have high ligations if you're mesenteric or the superior mesenteric. To speak the same language, we do have some terms. We again clarify that Hartmann's procedures mean that I have done a resection without an anastomosis, but I have resected, not just diverted. Second thing, anterior pelvic exentration means that we have removed the uterus with the bladder, and posterior pelvic exentration means that you have removed the uterus with the rectum, and then so you don't have an anterior and posterior in males. It's either pelvic exentration or no pelvic exentration because there is no anterior and posterior. In female, if we remove the three, it's total pelvic exentration. And then we have another term, either supra or infra elevator. This how was the level of cutting in the posterior exentration. So if I have done abdominal brunner resection and I have done removal of the vagina, it's an infra elevator resection. If I have done hysterectomy with anterior resection, it is supra elevator resection. Okay, so this one term that I would understand is not an abdominal brunner, or this is an abdominal brunner. I have removed the vagina or I didn't remove the vagina. Supra elevator versus infra elevator. Okay. So to anastomose or to divert. As a general rule, you cannot do an anastomosis in case of sepsis or perforation. So if you don't have a cervical cancer and there is a perforation in the colon or whatever, you cannot do primary anastomosis in the sepsis or in the perforation. And diversion will not solve this problem. So you have to do Hartmann's procedure. Anastomosis will not pass in the sepsis or in the pus. Okay. Second thing, you need to consider before doing an anastomosis, what's the degree of continence of this patient. So if the patient is already marginal continent before you remove the rectum, and then you have to remove the rectum or large part of the rectum and the rectal ampulla, then there will be much more incontinence. So incontinence anastomosis, stoma will be better for the patient than incontinent anastomosis. He will function better with a stoma than incontinent anastomosis. The other thing is it's very important. I do like to highlight that because sometimes residents understand that wrongly. Diversion doesn't protect a badly formed anastomosis. So you cannot do an anastomosis which is leaky and then do diversion and okay, I have done my job. It will pass. It will not pass. So he may not go in severe peritonitis and in severe sepsis and may not die from the anastomotic leak, but the anastomosis will develop stricture and will be persistently leaky. So you cannot have a bad anastomosis and then just divert. You need to do a good anastomosis and divert. Step 3, the anastomosis. So we have step 1, preparation. Step 2, section. Step 3, how to do the anastomosis. So there's some technical steps for the safe anastomosis. First, we do usually use either the Vicryl, the Dixon, or the BDS. You can find in some old literature, like in Kirk, which there is many box editions of that. He describes that using absorbable suture for the inner layer and silk suture for the outer layer. Okay, you can do that. But in general, the Royal College of Surgeons recommend BDS as even preferred on the Vicryl. So they recommend the BDS. And for the size of suture, the European Society of Coloproctology recommends 3.0 or 4.0. So the smaller sutures are better than 2.0 and the larger sutures. Single versus double layer anastomosis, there is no evidence which is better. So you can do, if you have a single layer anastomosis and it's tight, airtight, so it's enough. You may not take another layer or at least not complete another layer all around. And this is again simple for conel or simple sutures. Continuous or interrupted, again, those trials didn't show difference between two, although that the European Society of Coloproctology do recommend interrupted sutures in case of intestinal obstruction or bowel edema. So it's understandable that you have edema in the bowel loop, so you don't like to have Vicryl continuous suture and then they are all loose. So if there is edema or bowel obstruction, they do recommend taking interrupted sutures, and they do prefer interrupted suture in this case, even over Stabler. And this is the other question. So for Stabler or Hans-Sewen, in two meta-analyses, the incidence of stricture were one of them shows incidence of stricture was higher in circular Stabler with end-to-end anastomosis. And they claim in animal studies that this baby, because Stabler anastomosis healed by secondary intention and that Hans-Sewen healed by primary intention. So at least I cannot say that Stabler anastomosis is not superior. If it's not inferior, at least it's not superior to Hans-Sewen anastomosis. So again, in intestinal obstruction or edema, use sutures. For example, for low pelvic anastomosis or severe anastomosis, you cannot do good Hans-Sewen. So you are obliged to use the Stabler anyway. Okay. Inverting or everting suture, there's evidence that leak is lower with inverting suture. Is risk about 8% in inverting suture versus 43% an everted suture, so you need to invert the mucosa inside, not invert it to the outside. This is for our colleagues gynecologists. So how we do use the circular stabler? So for rectal surgery, we do usually use a size 31 or 33. Sometimes you use the 29 millimeter end-to-end anastomosis stabler. And we use silk or proline suture to take a purse string about the proximal end, both the anvil inside the proximal end, tighten the purse string, and then we introduce the stabler body through the anal canal till just in front or behind the suture or the stabler line, the closure line, okay? And we get out the tip of the stabler and tighten it to the anvil, confirm that there is no twist in the mesentery, and then fire. So we have 2 or 3 lines of circular stablers, okay? Then we need to check the donuts coming out. They are complete. So I have complete proximal donut, complete distal donut, so the anastomosis is tight. And then I do what we call air leak test, fill the pelvis with fluid, okay? And then, okay, so when we have circular stabler fired, like this proximal part, which is done by the circular suture, bursting suture, are cut by the stabler, by the knife of the stabler, and this distal segment all around are cut also by the knife of the stabler. Okay. Okay. So the circular line, which with the string suture, the burst string suture, and the sutures in the distal end all around are cut, because this is a stabler looks like there's 2 or 3 lines of sutures all staples all around and the knife in between. So you have the staples and then you fire the knife, cut a part proximal and a part distal. So they look like a donut. They are a circle with free empty inside. So it's like donuts. This is the farthest proximal and the farthest distal margin for you. This is why sometimes we bought the donuts for section, for histopathology, because this is the most proximal and the most distal part of the anastomosis. Okay. After that, we do what we call air leak test. So we fill the pelvis with fluid, saline, and inject air so through syringe, 50 centimeter syringe, and see if there is air bubbles. It's like what we do with the tire of the car. So if there is air bubbles, so there is leak. If there is leak, you need to revise the anastomosis, and you may consider both a diversion. So after we do small power section or any GI resection, we will have a window in the mesentery. Should we close this window? And this again something debatable. In open surgery, we used to close this window. When laparoscopic surgery take off, in most cases of colorectal and in many cases of GI of gynecology, they stopped to close this window because you can understand that it's more challengeable to close it with a laparoscopy with suture. So they stopped to do the closure of the window, and there's no much problems with that. So this was an important paper that they compare in reconstructive. So in patient doing bladder resection and doing ileal Bowel, they compared if they closed the window and if they didn't close the window, and they didn't find any increased GI complication or internal herniation or small bowel obstruction if they didn't close the window. So you may not close the window. Hmm? We never close it in laparoscopy, so why you close it in open? Mesenteric window. Mesenteric window. Okay. So step 4, diversion. When to do stoma? When to do stoma? So you can do stoma as palliative treatment because you have obstruction or fistula. As bridge therapy, I will do diversion and then I will give radiotherapy or chemotherapy and then I will do interval surgery. Or what we call Hartmann. So you have done the resection, but you didn't do anastomosis because there is sepsis or high risk of leak. In general, if you do primary anastomosis, you do need to cover with an ileostomy if the anastomosis is below the peritoneal reflection or very low, like 5 centimeters from air verge. If the pelvis is irradiated, if the albumin is below 30, if you have a patient with old age more than 60, or if you think that the anastomosis is somehow under tension. Any of which of this means that the risk of leak is high, may reach up to 10%. So you need to protect your patient, at least from peritonitis if the leak occurs. So you do good anastomosis and you do diversion also. How to construct the stoma? This you should have a stoma clinic anyway, or a stoma nurse. It should be trained to do that. Anyway, the classic site for putting the stoma is between the umbilicus, superior iliac spine, and the suprapubic region. And then you have to put it 5 centimeters away from the umbilicus, from wounds, and from the puny prominences. And you should check the patient while lying down, while sitting, and while standing, and put it away from the crease, so that the flange or the bag of the stomach can adhere without much leakage. In morbidly obese patient, sometimes the layer of fat is too thick that you cannot get stoma outside and spout it in a good side. So you can put it in higher up in the abdomen, especially also in patients which are paralyzed, so they can see the stoma and they can put the flange on the stoma and above the level of the umbilicus. Otherwise, this is a classic site for the stoma. We have three main types of the stoma. There's much more types, but colostomy, which we get the stoma colon outside. Ileostomy, we get the ileum outside. We don't normally get the jejunum outside because this will end up with short bowel syndrome, very high output and dehydration. And urostomy, when we put the ureters inside an ileum and get it to the outside. How to choose the stoma? So if I'm gonna do colorectal anastomosis, which is low than in patient over 60, low albumin or high risk anastomosis, I will do covering ileostomy, which is usually loop ileostomy. If in case of sepsis or patient with advanced cancer, which I don't think that he will bypass the anastomosis, I can do colostomy, and then I can do it as a loop in case of obstruction, or I can do it as end, especially in case of there is rectovaginal fistulas or things like that, to completely divert the stool away. Again, so if I'm doing colostomy, it will be on the left side. If I'm doing an ileostomy, it will be on the right side. That's how to compare ileostomy for colostomy. If I'm doing a colostomy, I can do it just flush, just suture to the skin. Like what in the left photo, this is a spout stoma. This is an ileostomy. I evert the edge of the ileum on the skin. But this one is flush, okay, which is the colostomy. Something technically difficult, I know. And again, I can do it what we call single spout. One spout at the proximal end, one not spouted the distal end, or double spout, both are spouted. And I can put bridge underneath if I think it's under tension or gonna be thrown inside, especially in obese patient, or I can do it without bridge if it's in patient and the stoma is coming out more simply. The main stoma problem or complication is that you need to, and our normal output is 5 to 10 milligram per kilogram per day. Usually, if the patient have more than 1 liter output of the stoma daily, they are at higher risk of developing dehydration, which may end up with pre-renal acute kidney injury. Okay, so take care of the output of the stoma. Parastomal hernia and stomal prolapse are very common, and you may need to bottom mesh, what we call keyhole or sugar baker, or reverse the stoma if this is feasible. Skin irritation and ulcer around the stoma, very common with ileostomy more than with the colostomy. And again, ischemia. So ischemia for the wall of the stoma. And the more important ischemia, if it's full thickness, if it is subfacial. So this will mean that the stoma will be retracted inside. If the ischemia is only in the mucosa and above the level of the fascia, you can conserve on that to bypass. Okay? Can understand that too. Very important. A good thing if you hear about, especially in locally advanced or centrally recurrent cervical cancer, is what we call double barrel with colostomy. I have done that like in 3 cases. I think Dr. Basil have done it in many cases also. We can publish our real experience shortly. So this is a very interesting topic. So rather than doing a total pelvic exentration and having 2 diversions, so we have an ileostomy for urine stoma, or ileal conduit, and have a colostomy on the left side. And so you have an ileal conduit and a colostomy, and you do have a more proximal GI small bowel anastomosis, which is again at high risk to leak, and we have encountered that in many cases. So rather than doing that, you can do one stoma without any anastomosis. So you can do what we call double barrel. It's like in the picture. I have done it in 3 patients, 1 cervical, one ovarian, and 1 advanced rectal cancer. Uretrosigmoidostomy, but it's not uretrosigmoidostomy. Yeah. But there is recent data about it. There is recent data about it, and it's very fascinating because you can divert the urine and the stool, and we don't have proximal anastomosis, so you don't have Three patient, exactly. It's not a posterior, it's a total pelvic exoneration. Mhm. So, yes, no. You have cut the descending colon. And then, so this is stable, this is closed or sutured anyway. And then you leave 10 to 15 centimeter, okay, and do an opening here. So the proximal part is getting a stool, and the distal part is 10 to 15 centimeter conduit for the urine. So I will put ureters here, 5 centimeter away from each other, and they are not in direct contact with the stool. They will fill up and get outside anyway. Because if this side will, and I will put stent on this ureters till I confirm that the anastomosis here is healed and that the distal end, the blind end is healed. After that, anyway, it will fail and get outside. Yeah, and you can do also in complication, treating complication. So you have a patient with urinary leak because rectal cancer infiltrating the bladder. You have removed a large part of the bladder, and you have leak from the ureter and from the bladder and anastomotic leak. So you can do that for both. Yes, the evidence still now is that pyelonephritis is less than the old ureter sigmoidosum. And again, why? Because the ureters are connected to blind end where there is no stool coming in this part. Yes, but will be minimal, not like the direct ureter sigmoidosum. And again, you are usually using it either in complication or in central recurrent cervical cancer, which don't have that long survival. And again, you don't have an anastomosis. There is the most important for me is that you are avoiding two openings and you avoiding internal anastomosis. No single anastomosis. Okay, so you should consider that. Which anastomosis? There is no anastomosis. Also, and you put a stent inside. That is safe, quite safe. So second thing, anastomotic leak, which I wrote in green because this is the color of the leak. Okay. Okay. I didn't put it as a step not to fix it now. Okay. So about the anastomotic leak, we do have incidence about 4%. The mortality may reach up to 34%, especially if there is a leak without proximal covering. So you will develop peritonitis and sepsis if there is a major leak. The standard treatment of leak is to take down the anastomosis. So you have a major leak from colorectal anastomosis, the standard is to wash and take down the anastomosis, not to divert proximally. Again, so in selected cases where the leak is not that major and the patient function reserve is good, you may consider do proximal diversion and wash and drainage without and trying to repair the anastomosis without taking it out. But you need to consider that 8.5% the leak may continue even after the proximal diversion. This is something to consider. Okay, very cautious when you are doing proximal diversion and leak. Yes. This is the stand. This is the stand. What? There is a leak already. How to prepare? There is a leak. No, I don't think. It's a question. If the European Center for Proctology audit, there is a decreased incidence of leak when it was preparation, both mechanical and oral, twice. And some claim that the oral is more important than the mechanical. If the leak occurred, whether the preparation will differ, I don't think, and there is no evidence that. So you already have a leak, and you manage the leak accordingly to the extent and the amount of coming out. And the standard is take down the anastomosis. Very cautiously if you're gonna do proximal diversion. Technical problem? Okay, Dr. Muhammad, if you have a question, we're hearing you.
هو دايما الستاندرد في الانستموتيك ليك is always to take down the anastomosis, no chance for observing the amount of fistula output. If it's low output fistula or if it's minimal leak, can we conserve or it's always you need always to
No,
take down the anastomosis?
no. If you have a minor leak, like small leak, and there is an abscess, but there is stool passing outside the anal canal, you can put drainage in this abscess. It looks like the Hinchey scoring system for diverticulosis if you look like that. So if you have an abscess cavity more than 5 centimeter, you need to drain it. If there is a quite a large amount of purulent pus and feces coming out from the wound or from the drain, you need to divert. Okay. So if it's an abscess, small amount, you can conserve. Large amount of abscess or evident stool, you need to open.
okay.
I have answered the question.
تمام. Thank you, Dr. Islam.
Okay. So this is the meta-analysis was done about anastomotic leak in ovarian cancer cytoreductive surgery, and they found that the only clinical risk factor was multiple small bowel resection anastomosis, so multiple anastomosis. So they do recommend against multiple anastomosis because this increases morbidity. You need to do minimum number of anastomosis, and if you need to do multiple resections, you need to divert the proximal one of them if it's feasible. Because multiple anastomosis. Anastomotic stricture, I have both the anastomotic stricture with the anastomotic leak because usually it is a consequence of the anastomotic leak. Okay, so usually, and this we see usually this not in the small bowel, in the colorectal anastomosis, and more if it is low. What happens that the blood supply in the edge is not good, and this will end up with leak, and the leak and the abscess will end up with more and more fibrosis, and they end up with a stricture around the anastomosis. So this is the common scenario. Usually, if there is a minor stenosis that you can pass the endoscope, it's dilatable with a balloon till you reach enough size, and you can close the stoma or continue with that. If it's very tight, you may need to take up the anastomosis and redo it again. Is there any alternatives to bowel resection or diversion? Yes. So this we can use a stent in selected cases if we have obstruction because there is infiltration of the rectum or of the colon from outside. We may use a stent to solve the problem as a bridge or an end-stage patient as a palliative treatment. You may put a stent. When to put the stent? The nice guidance would say that it's better on the left side because it's more difficult to put it in the right side. And I would say it's very difficult and very slippery if you put it in the lowest 7 or 8 centimeters. The stent will be slithering from the anal canal shortly. So you need to put on the left side, not in the low rectum and not on the right side. You can use an acute obstruction, offer a bridge or palliative treatment. And the evidence about the use of stent in non-colorectal cancer is limited. And from the limited evidence we do have, there is in one series, the management of patient with large bowel for recurrent gynecological cancer with stent appeared to be a reasonable option. This was the conclusion. But in another scenario, they found that the SIMS or the stent in extracolonic primary malignancy has failed in comparison to the colonic malignancy, so they don't recommend it. They recommend diversion rather than stent. There's limited evidence in a way. The final thing is the rectal injury in gynecology. So we have spoke about the preparation, the anastomosis, the anastomotic leak. Okay, so now about the rectal injury, and this will be usually in cervical cancer or in post-radiated pelvis. So the risk factor is prior pelvic surgery, salvage surgery. In case of cervical cancer, it sometimes be very bad, difficult surgery, and this why Dr. Khaled and Dr. Bassett usually say we don't need to give both modalities at the same time. So if the patient is gonna take radiotherapy, I would give. Okay. So local advanced tumor, surgeon expertise and patient characteristics may increase the risk of rectal injury. What can we do to decrease rectal injury? First, we need to do preoperatively assess well the patient and see if there is infiltration to be anticipated for that, doing bowel preparation, doing the surgery adequately from the beginning. Intraoperatively, we need to visualize the field well. You need to have an assistant getting the rectum away while you are dissecting posterior to the uterus. If there is injury, you need to detect intraoperatively and repair. At the end of the operation, if you are suspecting or have been shaving or dissecting very near to the rectum or the colon, you need to put an air leak test or push saline or methylene blue through the anal canal to see if there is any leak. It's better to treat intraoperative than giving it postoperative. Postoperative monitor for the signs of leak, which we will discuss later. So what are the signs of rectal injury? Early, you can detect intraoperative identification. Delayed, there will be abdominal pain, hypotension, fever, tachycardia, and usually fever is the beginning symptom. Usually this occurs in the 3rd to 5th day. There will be fever, maybe low grade at the beginning. and then you have tachycardia, and this may end up with peritonitis and septic shock, and you will have rising titer of the leukocytic count. You may end up with a fistula with the vagina or the stump of the uterus. Okay. In the meantime, to diagnosis of rectal injury was 2 to 3.5 days, ranging from 0 to 13 days in one study. How to detect, how to confirm? By an X-ray. You can see air under the diaphragm, especially if it didn't resolve in the 72 hours. Second, CT will confirm, and for small injuries, you can repair less than half the circumference of the bowel. You can repair in 2 layers. If it's more than that, you may need to do resection anastomosis, or you need to do a diversion. There is no specific algorithm for treatment of rectal injury in gynecology, and usually you will need broad-spectrum antibiotic for 5 to 7 days. Finally, the rectovaginal fistula, this usually, again, resulted from either from the tumor, advanced cervical cancer. So this is from the tumor or from the brachytherapy sometimes, or iatrogenic inside the operation. Usually you have a fistula, and the fistula opened in the vagina. We divide it in high and low. Low if it's the level of the anal dentate line, high if it's up in the rectum. Okay. To treat, if it's tumor related, you don't have any treatment beyond colostomy, or if you are doing resection and double bowel with colostomy, as we said. If it's treatment related, you need to conserve, if it's a small amount, as we said, Dr. Muhammad Banna, up to three months of conservation with antibiotic and the good drainage, and decreasing and increase fiber supplementation, and decrease the fluidity of the stool. After that, you may, if it's lower up, you may need do an advanced flap or perineal repair to put something or omentum between the vagina and the rectum. You may end up at the end needing a fecal diversion. This is the enhanced recovery protocol. Okay. So I will just not go direct in detail in that. We have a lecture about that, but I just highlighted early allowance of food intake. This is very important, because sometimes I see that the patient just have a serosal tear in the small bowel. You have a suture in serosal tear, which is of no value at all, and then you get the patient 5 days fasting from food for a serosal injury and repair, which cannot fistulate. Okay. Take home message, bowel involvement may reach up to 40% in advanced ovarian cancer patient. Adequate imaging and selective bowel preparation for left-sided colon, not for all gynecologic cases, left-sided involved colon. Anastomosis and diversion can be used alternatively or combined. Stent is an option with limited evidence in non-colorectal cancer patient, and in early oral should be encouraged in all patients, what we call the ERAS protocol. Thank you.
Yeah, thank you so much, and as usual, a very brilliant and a very smart presentation, and to the goal. The floor is open for any question from the physical or virtual attendees, but please, we want to go back to the take-home message. So do we have any question from the physical attendees? Amira.
Thanks, it was really nice. I just wanted to ask about incontinence. Do you mean like rectal incontinence?
If the patient already have an incontinence before rectal surgery, with rectal, sometimes have what we call low anterior resection syndrome, which is one of the symptoms is some sort of incontinence. So if it's already incontinent before surgery, it will be much incontinent surgery. So make the diversion rather than anastomosis.
So do we have any other comments or questions? اتفضل يا محمد.
I'm sorry, I didn't catch up to the part of bowel preparation. Came in the middle of the lecture.
اسمعها في الريكوردينج.
طيب تمام.
For the bowel preparation, there is no point for bowel preparation for small bowel like closure of ileostomy. There is nothing like that. You cannot prepare the small bowel. And for the large bowel, there is limited evidence on the right colon. And for the left colon, there is evidence and recommendation from American College of Surgery and from US Society of Coloproctology to prep this colon. But they do recommend, if you're gonna do preparation, don't do it only mechanical, do mechanical and oral with oral antibiotic.
تمام.
So,
انا كنت اسال
thank you so
فعلا.
much.
تمام.
عايز ايه يا محمد؟ قول.
وده زعل ان هو دايما دلوقتي الجديد ان كله بيقول الكيميكال باول بريباريشن بس اللي هو الانتي بايوتيك ويز وزاد ميكانيكال، فكنت هسأل امتى نضيف الميكانيكال وامتى ما نضيفوش للكيميكال.
رد عليها. شوف بس انت اول سلايد في البرزنتيشن اسمها في الريكوردينج that have been answered يا محمد.
طيب
اوكي.
تمام.
طيب just for the take home message and going through from a gynecological oncology point of view. For bowel involvement, I have two messages, please, Islam. The first, it is very, very common for the ovarian cancer to infiltrate the rectum or sigmoid and even the wall from outside. And please, what we usually say in our audit, don't do the practice of shaving the tumor from the surface of the rectum. So if the rectum is usually high up in the rectum, not the lower rectum, usually it is not the lower rectum or the inner canal, it's high up in the rectum or sigmoid, most commonly than rectum. So go directly. If you suspect invasion or going through the wall, go directly to have the R0 resection or the CC0 resection and resect the sigmoid, and you can do a primary anastomosis safely then, especially if the patient haven't got a new adjuvant chemotherapy. Okay, this is for the rectal or sigmoid part. So please, we have to abort or to decrease the policy of doing shaving, which is safe for the surgeon but is not the best for the patient oncological outcome. The other part that I want to enhance, Islam, is that usually the omentum is over the transverse colon. Sometimes you find the omentum, it looks like infiltrating the transverse colon, but usually what we see in more than 99.9% of cases that you can safely spare and preserve the transverse colon by doing meticulous dissection of the omentum. Even with heavily diseased omental, with omental cakes, you can spare the transverse colon. Very, very few cases that we have to do transverse colectomy. The practice of transverse colectomy have high rates of leakage. You should do either extended right or extended left, not just segmental transverse colectomy. But you can spare almost all the transverse colon. Just try to go dissect the omentum through the using the anterior two layers and posterior two layers, and even combine the blunt or sharp dissection, and mostly you will spare the transverse colon. So don't rush for doing a transverse colectomy when the omentum is infiltrated. For the second point, with adequate imaging and selective use of bowel, I want to enhance, because we are seeing as surgical oncologists many cases of cervical cancers which are advanced and recurrent after radiation or stomach carcinomas. Now I am shifting totally to use the PET MRI. So please remember or know there is a PET MRI, not only a PET CT. So you will combine both the advantage of MRI with delineation of the soft tissue in the pelvis, with the aerations of the rectum, with the bladder, with the cervical stump, and meanwhile you have the PET to see if there is any metastasis. So what I have been shifting throughout the last year is doing PET MRI, and it's available in Cairo, not available in Mansoura, but it's available in Cairo, and it's not so expensive to do PET MRI. So just remember this modality is present and is very useful in cervical and stomach carcinoma to use PET MRI. Just stent again. Stenting, I want to highlight in that most cases of recurrent ovarian cancer, the obstruction would be high up on the level of small bowel up to the stomach with extensive protein carcinomatosis. So our message usually for the general surgeons and the GIT surgeons and the gynecologists, this is a usual scenario, and we said it several times before, of this, almost all the ovarian cancer patient will die out of IO, of intestinal obstruction. And when you try for the first few years of practice to do exploration and to do diverting, you will not be able to do a diverting ileostomy colostomy because there is diffuse peritoneal carcinomatosis extending up from the jejunal or gastric level down. So there is no exploration for peritoneal carcinomatosis. Don't try. This is the end stage. You go conservative. It will pass once, twice, and thrice, and then she will die in the fourth or the fifth. So don't try to explore or do something for your patient. And to do a colonic stenting, this is very seldom. This is the exception when you have a large mass, just compressing the colon or something like that. So this is very, so this is very exceptional for that. And just that's all. And next week, we are going to complete the interesting chapter of module of complications. It would be the management of not only complications, but again, urological diversions and urological conduits and the complications of urological complications of gynecological oncology surgery, which are very common, the aortic injuries, the aortic transections, the bladder injuries, with Dr. Osama Azzat. Dr. Osama Azzat is one of the eminent and very upcoming stars of urology surgery in the Urology Center, Mansour University, which is famous worldwide as Ghonem Center. So he'll be with us next week to discuss the urological complications. And then the week after would be Iras, and then we are going to speak about the nearest part to my heart, which is the management of vascular and bleeding in gynecological oncology fields. Thank you, and see you next week. Thank you. Bye-bye.